I'm Philip Ward, Editor-in-Chief of Aren'tManyEurope.com. If you think of pulmonary embolisms, you think of Professor Martine Rémy Jardin from Lille. I'm very glad she's with me here today to talk about a session she's chairing on persistent controversies in pulmonary embolism. Professor Rémy Jardin, thank you very much for joining us.
You're welcome.
Could you tell us briefly what the persistent controversies are? What are people concerned about most at the moment?
I'm going to answer your question. I'm going to use the titles of the three lectures which are going to be given this afternoon. One of them is about the diagnosis of incidental PE, or the recognition of very tiny clots. And behind that the question is, should they be treated, should they be ignored? A practical question behind that. The second topic is what do we do when CT is not available, contraindicated or inconclusive? It's more for radiologists in order to try to improve our technique to avoid these inconclusive examinations. And the last talk will be about the role of CT not only as a diagnostic tool but also as a prognostic tool in acute PE. So three important topics for radiologists and clinicians.
Good. Now in Lille, how have you adapted your approach, your strategy to pulmonary embolism over the last year or two?
I think that this question is half for radiologists and half for clinicians. We improve our protocols, our scanning protocols with the evolution of CT technology. And we also have to work very regularly with clinicians to try to adapt the diagnostic strategy for acute PE, which is a frequent question, but not a frequent disease.
Okay, good. Now, I suppose this raises the issue of turf, that you've got to work very closely with your colleagues. How do you manage that process? How do you interact on a daily basis with other professions, other subspecialties?
I think that this question should be put to different categories of clinicians. Personally, I'm working in a hospital dedicated to chest diseases. So the question is very easily answered by CT, and there is a single way to search for acute PE because the disease is very non-specific in terms of clinical presentation. And in this particular category of patient, we have to have a look at the pulmonary arteries to say yes or no. And this cannot be replaced by another examination, particular VQ scintigraphy, because you may have alterations pre-existing to acute PE, so the diagnosis remains on the visualization of clots.
Okay. In a way, you've led me on to my next question, which was really about our readers who don't have access to CT, perhaps, who have other technologies, other techniques that people can make more use of for pulmonary embolism.
There are also other techniques, one which is not confidential, but for acute PE it remains confidential. It's MR, more for research of complement to CT. We can also talk about scintigraphy, which is interesting to consider, in particular accepted for the subset of patients like pregnant patients in order to save dose and also to limit the administration of contrast material. But I would say it's a personal opinion, but I think it will be shared by many people. CT remains the cornerstone for this diagnosis because you suspect acute PE, it's rarely acute PE, and the symptoms which generate this question may be explained by another disease. And the only technique to recognize what we call the alternative diagnosis is CT.
Okay, so CT is still king. King or queen. In terms of exciting developments and exciting initiatives within CT, is there something that you're very excited about at the moment?
I think that radiologists should be should follow carefully the technological advances in CT, because the speed of data acquisition, and in particular the temporal resolution reflecting the speed of acquisition in the plane of the section which is generated, it is very important because you suppress the motion artifacts which were a big problem in the previous decades. And the second point is that CT is no longer exclusively based on single energy, but we also have dual energy with perfusion imaging, and that may play also a role in the diagnosis and in the prognosis of this disease.
Okay. Do you think a lot has been done in the last few months, the last few years about dose, about reducing dose? Do you think this is enough has been done? Do you think further initiatives are necessary, further measures can be taken?
I think that we have tools, and the big question is how radiologists are going to use these tools, which are very efficient to reduce the dose. So to answer your question, everything depends where you start in terms of initial step. But the dose can be very, very low, and all the policy towards low kilovoltages is very, very efficient for CTA in general and acute PE in particular.
Okay. A couple of related issues this week at ECR. One of them is burnout and how to avoid the pressure of work, the work stresses, the work pressures. Do you have any advice for our audience on what they can do to reduce burnout risk?
Probably it's a consideration that happens with years, but probably we realize that we have to keep a distance between professional life, even if we are deeply involved, and personal life and other topics of interest in life to be able to reduce the pressure that can one day turn to be a burnout situation, which is clearly very difficult, but we know it happens.
Yes, sure. And for the other emphasis this week is on youth and trainees in radiology. Do you have any advice for those at the start of their career? Is there anything that perhaps they could do to improve their career at the moment?
I think that there are so many aspects in the professional decisions that we have to be careful, but probably something for which there will be a consensus is the necessity to remain very competent, to have the very high skills in order to be able to answer clinicians' questions and to play the expected role for a specialized radiologist. So skills, and they will probably find an area to be absolutely at ease in their professional career.
A final question is about radiology in France. There seems to be a lot of unrest at the moment, a lot of disputes over reimbursements, a lot of unhappiness about, particularly among private radiologists. Do you have any view on that, any perspective you could share with our listeners?
You're right, there are many questions still in debate in France. I'm not very at ease to answer for questions regarding private practice because I am working in a public hospital. And I could probably add a small element in the discussion from my personal experience. I think that we are all aware of the economic situation, and we know that we have to pay attention to many aspects regarding the income and the expenses, but I think that currently our main problem in hospitals is the hard pressure from administration, from which it's less and less possible to have discussion and to try to have a combined approach to solve and to better organize our daily life. So in public hospitals, here is the most important difficulty we face.
Excellent, good. Martine, thank you very much for your time. Thank you for sharing your views. Very, very interesting. We'd urge everyone to follow up. If you missed the session, this afternoon's session on PE, follow it online, and we wish you a successful week. This is Philip Ward for Aren't Many Europe, signing off.